Hello students and welcome back to my channel. This is the Children Nutrition series of videos, and today we're going to continue by talking about the metabolic diseases. Expect to learn the obesity, diabetes and eating disorders in children, as well as the dietary allergies and the celiac disease. Hi, I'm Tommy. I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize my classes so then I can explain and teach you the best and most valuable information you need to know. So let's begin this video by talking about the obesity. Okay, so children obesity and dyslipidemia. This is one of the most important chronic diseases we have nowadays. There are a lot of comorbidities, so diseases related to this one, such as insulin resistance, prediabetes and diabetes type 2, which indeed can contribute to the dyslipidemia. We also have early puberty, an hormonal imbalance and even gynecomastia. We can also have arterial hypertension and non-alcoholic fatty liver together with obesity. And there is a body image distortion. Some definitions. So we mentioned dyslipidemia. This is the alterations of the blood lipids. And the limits are for the cholesterol over 250 milligrams per deciliter. And for the triglycerides starting from 500 up to 1000 milligrams per deciliter. Screening. We have to do the screening for dyslipidemia in all children between 9 and 11 and from 17 to 21. And in the other ranges from 2 to 8 and from 12 to 16, only when there is a family history of dyslipidemia and cardiovascular events. What are the types of dyslipidemia? We have the primary, which is internal, that has to do with genetics, and the secondary, which is external. It has to do with diet, lifestyle, and diseases. Obesity. Well, in adults, it is basically when you have a body mass index over 30. In children, the Spanish cross-sectional study of 2008 says that obesity is over the percentile 95 in children. And the World Health Organization obesity charts say that obesity is 2 standard deviations from the normal. Metabolic syndrome. Well, in ages between 10 and 16, the criteria is based on age and sex-specific percentiles, and over 16, it is based on specific cutoff values, same as adults more or less. And this has to do with waist circumference, blood pressure and blood lipids, again, the dyslipidemia. What is the etiology? Well, there is a genetic basis, of course. Polygenic, 95% of the cases. And monogenic, which has to do with one gene in particular, only 5%. This is, for example, the leptin-melanocortin axis, the hypothalamic development, or the polymalformative syndrome. For example, an error with the leptin, which is the satiety hormone, will inhibit the satiety, and indeed you will end up eating more than what you need. On the other hand, secondary causes are derived from central nervous system alterations, endocrine diseases, and also iatrogenesis, which is the disease of one's own. What are the warning signs of monogenic obesity? Well, the early onset severe obesity, a strong family history, of course, a resistance to traditional weight loss methods, and the developmental and physical abnormality. Talking about complementary tests, we have the first level, the cholesterol, the ALT and AST, which are hepatic enzymes. These are present in the blood when there is an hepatic damage. Glucose, of course, insulin, thyroid parameters, very important for the metabolism, and vitamin D. On the second level, we also have the abdominal ultrasound. This is only done when the ALT is elevated, when there is a liver damage. The oral glucose tolerance test to check how glucose is tolerated. Also the hemoglobin A1C to check the average glucose levels in the last 3 months. And the bone age, together with cortisone. And then we have the treatment. Well, we have the NutriPlate to follow here. This is to fill a plate with 50% of vegetables, 25% of meats and fish, this is indeed proteins, and 25% of cereals, carbs. Then exercise and a healthy diet. So every day, as often as possible, play outside, take the stairs instead of the lift, go for a walk, be active, then do some aerobic exercise or recreational activities 3 to 5 times a week. And 2 to 3 times a week, maybe incorporate some strength and flexibility. And of course, cut down on TV, video games and computer screens in general. The medication, well, the orlistat, metformin, setmelanotide, and the famous GLP-1 analog. This is the Ozempic. And for dyslipidemias, the treatment is a heart-healthy diet and exercise, similar to this one. Medications can be statins, ezetimibe, the PCSK9 inhibitors, omega-3s, and fibrates. When applying these medications, we have to monitor and consider the possible side effects. Okay, so now it's time to take a look at diabetes. Diabetes, the epidemiology, the prevalence. Well, this is interesting, mainly in Scandinavia, in northern countries, but also a lot in Spain and specifically in the Canary Islands. What are the types of diabetes? We have type 1, which is autoimmune, or maybe idiopathic, and this is called the type 1B because it can be acquired. For example, when there is a pancreas damage or it stops to work properly. And the type 1 diabetes is the one that prevails in the clinic. On the other hand, the type 2 diabetes is the one related to the insulin resistance. Glycemic control goals. The Pediatric Institute says that we have to maintain the glucose levels below 130 milligrams per deciliter pre-prandial, this is before eating a meal, 180 after, so post-prandial, and less than 140 at bedtime. And we have to do this to minimize significantly the blood glucose fluctuations. And to do that, we have the glucose meters. These can be capillary blood glucose or interstitial glucose sensors linked to an insulin pump, for example. And the insulin administration can be done either subcutaneous with multiple daily injections with basal insulin and postprandial insulin, so after the meals, or maybe continuous with an infusion pump. This has a sensor and is automated insulin delivery. The initial assessment and dietary history. So we have to review the dietary history, the eating habits, the food choices, the fat intake, the meal times, and also the daily activities of the child. The nutritional recommendations and healthy eating, well, healthy diet. It's very similar to a non-diabetic. We have to adjust for proper carbohydrate counting and make sure that we obtain growth, very important. Macronutrient distribution is, again, very similar. 40 to 50% of carbs, 30 to 40% of fats, and 15 to 25% protein. The carbohydrate servings, this is very interesting. So one serving of carbohydrates is 10 grams of carbs, and that equals to 40 calories. And the number of servings per day is the child's age plus 10. So if a child is 7 years old, then 17 servings a day. General recommendations are to avoid saturated fats, trans fats, and excessive sodium in the diet, and to include whole grains, vegetables, fruits, healthy fats, and fiber. So we have to control the postprandial blood glucose, so the one after the meal. And we do this taking in account glycemic index of food, as well as the glycemic load. And we also have to take in account fat and proteins, because the fat protein unit equals to 100 calories more or less, and it requires one insulin serving. So it's similar to one serving of carbohydrate. And there is also the insulin carbohydrate ratio to take in account. A low-carb diet is not scientifically proved to improve the glycemic control. There is a potential nutrient deficiency as well when done in children. So be careful with that. And of course, alcohol is very, very bad. You have to be very careful because it reduces the perception of an hypoglycemia and it can be fatal. And the physical exercise, well, we have to adjust the insulin as well as the dietary intake of carbohydrates and use isotonic drink to not lose those minerals. On the other hand, taking a look at type 2 diabetes, the approach is very similar to type 1. We have to promote healthy habits to prevent obesity, and here we also have to avoid malnutrition and eating disorders. So as you can see, it has a lot more to do with psychology and habits. And now, as we mentioned eating disorders, let's take a look at them in more detail. This is not a typical patient. It has physical alterations. They are often children in growth and development. Nutritional alterations. They may have issues such as diabetes, obesity, they have myths and fears, and also psychological. There is a body image distortion, a lower self-esteem, phobias, anxiety, and compulsions. So this requires a very careful and specialized management. There is no a one-size-fits-all approach. The definition is a persistent alteration with multifactorial biopsychosocial etiology. This, in other words, means that it can come from different areas of our life: biological, psychological, and social as well. There is an increased likelihood of developing an eating disorder if a family member has it. What are the myths and realities? It is not just a young female university student's thing. It's not the parents' fault, and it's not a phase of growth or attention-seeking behavior. The epidemiology, it is the third chronic disease in adolescents, very important. And around 10% of the population has it. And there is a higher comorbidity. That means it goes related with other diseases. And the chronicity is without diagnosis and treatment. The prognosis is high mortality from comorbidities or even suicide, which is very bad. And there is a better prognosis at a younger age. So if we treat this early, it's always going to be better. The diagnostic criteria. So this is very simple. We have the anorexia, bulimia, and binge eating disorder. The anorexia is food restriction, fear of gaining weight, and an altered body image perception. It's commonly related to amenorrhea and females as a criteria, and it can be a restrictive type or a binge eating purging type, if there is an episode in the last 3 months of binge eating or purging. On the other hand, bulimia is a binge eating with compensatory behaviors, at least once a week in the last 3 months. On the other hand, binge eating disorder is only binge eating without compensatory behavior. Underlying all, they have a distorted body image, lower self-esteem, fear, anxiety, and guilt. And they also share an unhealthy relationship with food, myths, and preconceived ideas. The warning signs: weight loss or failure to gain suddenly interest in healthy food, checking rituals such as weighing, measuring, and the mirror. Non-specific symptoms: control over meals, avoiding eating with family or in public, hyperactivity, unexpectedly losing weight, and hiding food, as well as going to the bathroom after the meals, weight fluctuations, amenorrhea, and psychological changes. What are the dietitian steps then? Well, to recognize, to ask questions, and always look for a multidisciplinary approach. Screening questionnaires are also very good to identify this, and we have to be careful to not confuse it with an endocrine or gastrointestinal alteration, with infections, pregnancy, cancer, psychiatric, or depression. The initial steps, the treatment pillars, are 3. Nutritional rehabilitation, medical monitoring, and psychological treatment. The objectives: nutritional rehabilitation, we have to explain why the body isn't well. We have to normalize eating patterns, so it's not the time for dissociated diets such as fasting, keto, vegan, vegetarian, paleo. No, we have to normalize it. And of course, psychological treatment. We have to try to eliminate that binging and purging. And here the parents are in charge, because they are feeding the child indeed, and they must correct and create healthy habits for them. And the outpatient treatment can be either day hospital or pediatric hospitalization. So now let's continue with the dietary allergies. Allergic reactions can be either immunological or non-immunological. Inside the immunological, we have them mediated by IgE, immunoglobulin E, or non-mediated by IgE. These are intolerances. The mediated ones are factors affecting allergic reactions, and this can be genetics, age, diet, and even fruits. Non-immunological, on the other hand, can be toxic or non-toxic. These are metabolic, enzymatic, pharmacological, or indeterminate. Immunology. So there are sensitization phases and effect phases. The sensitized tolerants have high IgE but no symptoms. And there is a major and minor allergens. There are different effects depending on the allergen, of course. There is cross-reactivity. This is very interesting. So if you become sensitized to a compound, you can become allergic to another very similar to it. Different mammal milks. So for example, if you are allergic to goat milk, chances are you're going to be allergic to sheep milk as well. And to correct this, what they are doing is the epitope modification. This is the binding site between the antigen and the antibody. And a modification could make that protein tolerated. So for example, cow's milk or goat's milk can be tolerated with this modification of the epitope. For example, denaturing the food protein is an epitope modification. Heating, for example, is a very good method. This creates the baked milk, which is indeed when we expose our milk to warm temperatures. And many people can tolerate that way better than the raw milk. So now let's take a look at more in detail the IgE-mediated allergy. So the symptoms are very rapid: dermatitis, itching, urticaria, angioedema, cough, sneezing, bronchospasms, and possible anaphylaxis. Diagnosis: we have the clinical history. So we have to correlate the food intake with the symptoms. The tests: we have to measure the IgE in the blood. We're using, for example, the prick test, skin test on the forearms. This is the one we do here. The provocation test, which is the exposure to the allergen. This can be dangerous because we are exposing an allergic person to an allergen. And there can be an anaphylactic shock. and complementary tests as well, which is the prick test or the prick test. The prick test is with the food itself. So not with the isolated protein, but with the food. And the specific IgE tests as well are complementary. So here we have to say that when you are allergic to beef, 100% you are allergic to cow's milk. Many are not allergic to beef because it is usually eaten cooked. Again, as we said here, a modification could make that protein tolerated. And again, as we said, allergic to cow milk proteins, heat resistant and cross-react with milk from other mammals. Same thing we said here. The prognosis, 10% have persistence at 7 years. Poor prognosis and confirmation every 6 months. So for example, after implementing the treatment in the egg allergy, 50% develop the tolerance at 3 to 4 years. And it is way better with cooked eggs. Again, as we said, denaturing the protein. On the other hand, we can also do an induction of the oral tolerance. This is starting with the maximum tolerated doses and continue to expose to that substance to finally tolerate it a bit or desensitize. This is trying to hack the immune system. And the prevention, no need to make any changes to the mother's diet. And we have to follow the usual complementary feeding schedule. The treatment is the exclusion of cow's milk proteins from the diet. Breast milk, restricting the mother. Cow's milk proteins can pass into the breast milk, so be careful with that. The artificial milk, special formulas without those proteins. And mixed feeding, so after we introduce the complementary nutrition, does not require removing dairy products from the mother's diet. And if there is a good tolerance with the modified food, we have to maintain the normal complementary feeding. Special formulas, not from milk of other animals. We have to use hydrolyzed milks, extensively hydrolyzed or elemental formulas, and from other protein sources such as soy. Soy, though, has a problem. It contains isoflavones, which are phytoestrogens, and also phytates, which are anti-nutrients. So these are things to take in account, because they can create an hormonal imbalance and lower the nutrient absorption. And rice as a second line, but soon it will become a first line. On the other hand, we have the non-IgE mediated the symptoms: allergic proctocolitis, blood and mucus in the feces due to cow's milk protein, allergic enteropathy, such as vomiting, diarrhea, and abdominal distension. This is possible growth failure related, and due to cow's milk, soy, egg, and wheat. Food protein-induced enterocolitis syndrome due to FODMAPs. These are the carbohydrates that are very short and can be fermented in the gut. Acute repeated vomiting, watery diarrhea, and blood and mucus in feces. And chronic, on the other hand, make a differential diagnosis, so do not confuse it with the enteropathy. And allergic dysmotility, stimulation of gastroesophageal reflux, delayed gastric emptying, plus distension and constipation. First is to improve the habits, less food, and the second is the cow's milk or soy allergy. And the third one is the omeprazole. The diagnosis, well, we have the clinical history and the physical examination. Again, remember the ABCD, that's very easy to remember, right? Elimination test and provocation test as well. And we have to check the biomarkers, specific IgE and skin test. So very similar to the previous one. And the treatment, same as before. But if removing the allergen in the mother is not enough, another allergen should be removed, for example the eggs. And special formulas should be considered. And last but not least, we have to talk about celiac disease. So, it affects many other organs and systems, not just the digestive tract. Very important to remember it. This is a systemic disease of an immunological nature. It is due to a consumption of gluten and other gliadins with genetic predisposition. Gluten is found in species of the genus Triticum. This is hard wheat, spelt wheat, kamut, triticale, barley, rye, and also oats. They should be gluten-free ideally and naturally, but some more sensitive individuals are affected by cross-contamination. Indeed, the majority of oats are cross-contaminated with gluten. The prevalence and risk factors increased in the diagnosis of celiac disease, prevalence of 1.4% of the world population, and in Europe there are 3 to 13 cases per 1,000 children, and it is more frequent in girls. Many patients are asymptomatic, so it's very important to take into account this thing. Etiology is due to genetic, mostly DQ2 or DQ8, these are gene modifications, environment, very interesting, and immunology. Symptoms and signs. The digestive symptoms and signs are chronic diarrhea, abdominal distension, nausea, constipation, and general pain. Extradigestive, non-classical or atypical, include the failure to thrive, iron deficiency anemia, liver abnormalities, recurrent oral ulcers, and short stature. Delayed puberty, amenorrhea, dermatitis herpetiformis. Not all have celiac disease, but all celiacs have it. This is a very unpleasant pathology in the skin in certain areas of the body. Neuropathy, malabsorption of vitamin B12, chronic fatigue, irritability, bone fractures, osteoporosis, poor absorption of calcium and vitamin D, which can lead to dental enamel defects. As you can see, there is a general nutrient deficiency due to a lower absorption of the nutrient. Diagnosis: clinical as given ABCD, anthropometry, biochemistry, clinical, and diet. Serology: the patient must be consuming gluten to do a serology test, and it requires a transagglutinase antibody along with the total IgA levels. And when the serology tests give us a result of 10x of AATG, AGA, means that there is a lesion in the epithelium. Also request anti-endomyosal antibodies, AE, and anti-deaminated gliadin peptide antibodies. These are the IgG antibodies, for example. Regarding genetics, though, the HLA class 2 discovers the DQ2 in 95% of celiacs versus the 20% in control groups and DQ8 in the rest. So this means if you have these modifications, the DQ2 in the 95% of people and the DQ8 in the rest, there is a high probability of being celiac, but it's not determinative. Biopsy, on the other hand, is no longer essential and is still necessary only in diabetics. So those who have IgA deficiency and those who have the AATG, IgA values, so these ones right here, below 10x of normal. Recommendations: if a patient is found to be allergic with serological testing, genetic testing is not necessary, which is also very expensive and only estimates the probability. Again, here, the most important one is the serology test. And if we find glycosyl inositol phospholipids in feces, it means that there is an immunogenic gluten peptide in the feces as well. And that is due to a resistance to digestion and is used to analyze adherence to a gluten-free diet. And then you have to know that there is a list of foods that may contain gluten. And we have to be careful with the processed and bulk products because of the cross-contamination. Remember the oats. Fresh foods are generally gluten-free. And gluten-free products must have less than 20 parts per million of gluten to be considered safe. Those with very low gluten content, they contain around 20 to 100 parts per million and are not suitable for celiacs. It does not have nutritional declaration, so we have to check the ingredients and look for possible traces of gluten. So you have to be careful if you are celiac. Okay, this is it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Don't forget to like, subscribe, and turn on the notifications so you get notified every time I upload a new video. If you find value in this, please share it to your friends and family to spread this knowledge to them as well. Thank you so much for watching, and I will see you in the next one, in which we are going to talk about the gastrointestinal tract related diseases. Hope you enjoyed. Ciao!